Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Neoadjuvant immunotherapy in locally advanced mismatch repair deficient colon cancer. Background. Mismatch repair deficient, DMMR, tumors can be found in 10 to 15% of patients with non-metastatic colon cancer. In these patients, the efficacy of chemotherapy is limited. The use of neoadjuvant immunotherapy has shown promising results, but data from studies of this approach are limited. Methods. We conducted a phase 2 study in which patients with non-metastatic, locally advanced, previously untreated DMMR colon cancer were treated with neoadjuvant nivolumab plus ipilimumab. The two primary endpoints were safety, defined by timely surgery, i.e., less than or equal to 2-week delay of planned surgery owing to treatment-related toxic events, and 3-year disease-free survival. Secondary endpoints included pathological response and results of genomic analyses. Results. Of 115 enrolled patients, 113, 98%, 97.5% confidence interval, CI, 93 to 100, underwent timely surgery. 2 patients had surgery delayed by more than 2 weeks. Grade 3 or 4 immune-related adverse events occurred in 5 patients, 4%, and none of the patients discontinued treatment because of adverse events. Among the 111 patients included in the efficacy analysis, a pathological response was observed in 109, 98%, 95% CI, 94 to 100, including 105, 95%, with a major pathological response, defined as less than or equal to 10% residual viable tumor, and 75, 68%, with a pathological complete response, 0% residual viable tumor. With a median follow-up of 26 months, range 9 to 65, no patients have had recurrence of disease. Conclusions. In patients with locally advanced DMMR colon cancer, neoadjuvant nivolumab plus ipilimumab had an acceptable safety profile and led to a pathological response in a high proportion of patients. Self-expanding or balloon-expandable TAVR in patients with a small aortic annulus. Background. Patients with severe aortic stenosis and a small aortic annulus risk for impaired valvular hemodynamic performance and associated adverse cardiovascular clinical outcomes after transcatheter aortic valve replacement, TAVR. Methods. We randomly assigned patients with symptomatic severe aortic stenosis and an aortic valve annulus area of 430 square millimeters or less in a 1-to-1 ratio to undergo TAVR with either a self-expanding supraannular valve or a balloon-expandable valve. The co-primary endpoints, each assessed through 12 months, were a composite of death, disabling stroke, or rehospitalization for heart failure, tested for non-inferiority, and a composite endpoint measuring bioprosthetic valve dysfunction, tested for superiority. Results. A total of 716 patients were treated at 83 sites in 13 countries. Mean age, 80 years, 87% women. Mean Society of Thoracic Surgeons predicted risk of mortality, 3.3%. The Kaplan-Meier estimate of the percentage of patients who died, had a disabling stroke, or were rehospitalized for heart failure through 12 months, was 9.4% with the self-expanding valve, and 10.6% with the balloon-expandable valve. Difference, minus 1.2 percentage points, 90% confidence interval, CI, minus 4.9 to 2.5. P less than 0.001 for non-inferiority. The Kaplan-Meier estimate of the percentage of patients with bioprosthetic valve dysfunction through 12 months was 9.4% with the self-expanding valve and 41.6% with the balloon-expandable valve. Difference, minus 32.2 percentage points, 95% CI, minus 38.7 to minus 25.6, p less than 0.001 for superiority. The aortic valve mean gradient at 12 months was 7.7 mm Hg with the self-expanding valve and 15.7 mm Hg with the balloon-expandable valve, and the corresponding values for additional secondary endpoints through 12 months were as follows: mean effective orifice area 1.99 square centimeters and 1.50 square centimeters, percentage of patients with hemodynamic structural valve dysfunction 3.5% and 32.8%, and percentage of women with bioprosthetic valve dysfunction 10.2% and 43.3%, all p less than 0.001. Moderate or severe prosthesis patient mismatch at 30 days was 5 in 11.2% of the patients in the self-expanding valve group and 35.3% of those in the balloon-expandable valve group, p less than 0.001. Major safety endpoints appeared to be similar in the two groups. Conclusions. Among patients with severe aortic stenosis and a small aortic annulus who underwent TAVR, a self-expanding supraannular valve was non-inferior to a balloon-expandable valve with respect to clinical outcomes and was superior with respect to bioprosthetic valve dysfunction through 12 months. Next, we will be discussing articles from Journal of American Medical Association, Home Blood Pressure Telemonitoring and Nurse Case Management in Black and Hispanic Patients with Stroke. A randomized clinical trial. Importance: Black and Hispanic patients have high rates of recurrent stroke and uncontrolled hypertension in the U.S. The effectiveness of home blood pressure telemonitoring, HBPTM, and telephonic nurse case management, NCM, among low-income Black and Hispanic patients with stroke is unknown. Objective: to determine whether NCM plus HBPTM results in greater systolic blood pressure, SBP, reduction at 12 months and lower rate of stroke recurrence at 24 months than HBPTM alone among Black and Hispanic stroke survivors with uncontrolled hypertension. Design, setting, and participants: practice-based, multi-center, randomized clinical trial in 8 stroke centers and ambulatory practices in New York City. Black and Hispanic study participants were enrolled between April 18, 2014, and December 19, 2017, with a final follow-up visit on December 31, 2019. Interventions: participants were randomly assigned to receive either HBPTM alone, 12 home BP measurements/week for 12 months, with results transmitted to a clinician, N equals 226, or NCM plus HBPTM, 20 counseling calls over 12 months, N equals 224. Main outcomes and measures. Primary outcomes were change in SBP at 12 months and rate of recurrent stroke at 24 months. Final statistical analyses were completed March 14, 2024. Results among 450 participants who were enrolled and randomized: mean SD, age, 61.7, 11.0 years, 51% were Black, N equals 231, 44% were women, N equals 200, 31% had greater than or equal to 3 comorbid conditions, thus N equals 137, 72% had household income less than $2,500/Y, N equals 234, 324, 358, 80% completed the trial. Those in the NCM plus HBPTM group had a significantly greater SBP reduction than those in the HBPTM alone group at 12 months, minus 15.1 mm Hg, 95% CI, minus 17.2 to minus 13.0, versus minus 5.8 mm Hg, 95% CI, minus 7.9 to minus 3.7 respectively, p less than 0.001. The between-group difference in SBP reduction at 12 months, adjusted for primary care physician clustering, was minus 8.1 mm Hg, 95% CI, minus 11.2 to minus 5.0, p less than 0.001, at 12 months. The rate of recurrent stroke was similar between both groups at 24 months, 4.0% in the NCM plus HBPTM group versus 4.0% in the HBPTM alone group, p greater than 0.99. Conclusions and relevance among predominantly low-income Black and Hispanic stroke survivors with uncontrolled hypertension. Addition of NCM to HBPTM led to greater SBP reduction than HBPTM alone. Additional studies are needed to understand the long-term clinical outcomes, cost-effectiveness, and generalizability of NCM-enhanced telehealth programs among low-income Black and Hispanic stroke survivors with significant comorbidity. Mortality and morbidity in adults with rheumatic heart disease. Importance: rheumatic heart disease, RHD, remains a public health issue in low and middle-income countries, LMICs. However, there are few large studies enrolling individuals from multiple endemic countries. Objective: to assess the risk and predictors of major patient-important clinical outcomes in patients with clinical RHD. Design, setting, and participants: multi-center, hospital-based, prospective observational study, including 138 sites in 24 RHD endemic. Main outcomes and measures. The primary outcome was all-cause mortality. Secondary outcomes were cause-specific mortality, heart failure, HF, hospitalization, stroke, recurrent rheumatic fever, and infective endocarditis. This study analyzed event rates by World Bank country income groups and determined the predictors of mortality using multivariable Cox models. Results: between August 2016 and May 2022, a total of 13,696 patients were enrolled. The mean age was 43.2 years and 72% were women. Data on vital status were available for 12,967 participants, 94.7%, at the end of follow-up. Over a median duration of 3.2 years, 41,478 patient years, 1943 patients died, 15% overall, 4.7% per patient year. Most deaths were due to vascular causes, 1,312, 67.5%, mainly HF or sudden cardiac death. The number of patients undergoing valve surgery, 604, 4.4%, and HF hospitalization, 2% per year, was low. Strokes were infrequent, 0.6% per year, and recurrent rheumatic fever was rare. Markers of severe valve disease, such as congestive HF, HR, 1.58, 95% CI, 1.50 to 1.87, p less than 0.001, pulmonary hypertension, HR, 1.52, 95% CI, 1.37 to 1.69, p less than 0.001, and atrial fibrillation, HR, 1.30, 95% CI, 1.15 to 1.46, p less than 0.001, were associated with increased mortality. Treatment with surgery, HR, 0.23, 95% CI, 0.12 to 0.44, HR, 0.24, 95% CI, 0.06 to 0.95, p equals 0.042, were associated with lower mortality. Higher country income level was associated with lower mortality after adjustment for patient-level factors. Conclusions and relevance: mortality in RHD is high and is correlated with the severity of valve disease. Valve surgery and valvuloplasty were associated with substantially lower mortality. Study findings suggest a greater need to improve access to surgical and interventional care, in addition to the current approaches focused on antibiotic prophylaxis and anticoagulation. Next, we will be discussing articles from Annals of Internal Medicine. Background: contemporary prostate cancer, PCA, screening uses first-line prostate-specific antigen, PSA, testing, possibly followed by multiparametric magnetic resonance imaging, MPMRI, for men with elevated PSA levels. First-line biparametric MRI, BPMRI, screening has been proposed as an alternative. Objective: to evaluate the comparative effectiveness and cost-effectiveness of first-line BPMRI versus PSA-based screening. Design. Decision analysis using a microsimulation model. Data sources. Surveillance, epidemiology, and end results database, randomized trials. Target population. U.S. men aged 55 years, with no prior screening or PCA diagnosis. Time horizon. Lifetime. Perspective. U.S. healthcare system. Intervention. Biennial screening to age 69 years, using first-line PSA testing, test positive threshold, 4 micrograms/L, with or without second-line MPMRE or first-line BPMRE, test positive threshold, PI-RADS, prostate imaging reporting and data system, 3 to 5 or 4 to 5, followed by biopsy, guided by MRI or MRI, plus transrectal ultrasonography. Outcome measures. Screening tests, biopsies, diagnoses, overdiagnoses, treatments, PCA deaths, quality-adjusted and unadjusted life years saved, and costs. Results of base case analysis. For 1,000 men, first-line BPMRI versus first-line PSA testing prevented 2 to 3 PCA deaths and added 10 to 30 life years, 4 to 11 days per person, but increased the number of biopsies by 1,500, 6 to 4,174, and the number of overdiagnoses by 38 to 124, depending on the biopsy imaging scheme. At conventional cost-effectiveness thresholds, first-line PSA testing with MPMRE, followed by either biopsy approach for PI-RADS 4 to 5, produced the greatest net monetary benefits. Results of sensitivity analysis. First-line PSA testing remained more cost-effective, even if BPMRE was free. All men with low-risk PCA underwent surveillance, or screening was quadrennial. Limitation. Performance of first-line BPMRE was based on second-line MPMRE data. Conclusion. Decision analysis suggests that comparative effectiveness and cost-effectiveness of PCA screening are driven by false positive results and overdiagnoses, favoring first-line PSA testing with MPMRI over first-line BPMRI. Next, we will be discussing articles from British Medical Journal. Mailed feedback to primary care physicians on antibiotic prescribing for patients aged 65 years and older. Pragmatic, factorial randomized controlled trial. Abstract. Objectives to evaluate whether providing family physicians with feedback on their antibiotic prescribing, compared with that of their peers, reduces antibiotic prescriptions. To also identify effects on antibiotic prescribing from case mix adjusted feedback reports and messages, emphasizing antibiotic-associated harms. Design pragmatic, factorial randomized controlled trial, setting primary care physicians in Ontario, Canada. Participants, all primary care physicians were randomly assigned a group, if they were eligible, and actively prescribing antibiotics to patients 65 years or older. Physicians were excluded if had already volunteered to receive antibiotic prescribing feedback from another agency, or had opted out of the trial. Intervention. A letter was mailed in January 2022 to physicians with peer comparison antibiotic prescribing feedback, compared with the control group, who did not receive a letter, 4-to-1 allocation. The intervention group was further randomized in a 2x2 factorial trial to evaluate case mix adjusted versus unadjusted comparators, and emphasis, or not, on harms of antibiotics. Main outcome measures antibiotic prescribing rate per 1,000 patient visits for patients 65 years or older, 6 months after intervention. Analysis was in the modified intention to treat population using Poisson regression. Results. 5,046 physicians were included and analyzed, 1,005 in control group, and 4,041 in intervention group, 1,016 case mix adjusted data and harms messaging, 1,006 with case mix adjusted data and no harms messaging, 1,006 unadjusted data and harms messaging, and 1,013 unadjusted data and no harms messaging. At 6 months, mean antibiotic prescribing rate was 59.4, standard deviation 42.0, in the control group, and 56.0, 39.2, in the intervention group, relative rate 0.95, 95% confidence interval 0.94 to 0.96, Unnecessary antibiotic prescribing, 0.89, 0.86 to 0.92, prolonged duration prescriptions defined as more than 7 days, 0.85, 0.83 to 0.87, and broad-spectrum prescribing, 0.94, 0.92 to 0.95, were also significantly lower in the intervention group compared with the control group. Results were consistent at 12 months post-intervention. No significant effect was seen for including emphasis on harms messaging. A small increase in antibiotic prescribing with case mix adjusted reports was noted, 1.01, 1.00 to 1.03. Conclusions: peer comparison audit and feedback letters significantly reduced overall antibiotic prescribing with no benefit of case mix adjustment or harms messaging. Antibiotic prescribing audit and feedback is a scalable and effective intervention and should be a routine quality improvement initiative in primary care. Next, we will be discussing articles from Lancet. Worldwide Trends in Underweight and Obesity from 1990 to 2022. A pooled analysis of 3,663 population representative studies with 222 million children, adolescents, and adults. Background: underweight and obesity are associated with adverse health outcomes throughout the life course. We estimated the individual and combined prevalence of underweight or thinness and obesity, and their changes, from 1990 to 2022, for adults and school-aged children and adolescents, in 200 countries and territories. Findings: from 1990 to 2022, the combined prevalence of underweight and obesity in adults decreased in 11 countries, 6% for women and 9% for men, with a posterior probability of at least 0.80 that the observed changes were true decreases. The combined prevalence increased in 162 countries, 81% for women, and 140 countries, 70% for men, with a posterior probability of at least 0.80. In 2022, the combined prevalence of underweight and obesity was highest in island nations in the Caribbean and Polynesia and Micronesia, and countries in the Middle East and North Africa. Obesity prevalence was higher than underweight, with posterior probability of at least 0.80 in 177 countries, 89% for women, and 145, 73% for men in 2022, whereas the converse was true in 16 countries, 8% for women, and 39, 20% for men. From 1990 to 2022, the combined prevalence of thinness and obesity decreased among girls in 5 countries, 3%, and among boys in 15 countries, 8%, with a posterior probability of at least 0.80, and increased among girls in 140 countries, 70%, and boys in 137 countries, 69%, with a posterior probability of at least 0.80. The countries with highest combined prevalence of thinness and obesity in school-aged children and adolescents in 2022 were in Polynesia and Micronesia, and the Caribbean for both sexes, and Chile and Qatar for boys. Combined prevalence was also high in some countries in South Asia, such as India and Pakistan, where thinness remained prevalent, despite having declined. In 2022, obesity in school-aged children and adolescents was more prevalent than thinness, with a posterior probability of at least 0.80 among girls in 133 countries, 67%, and boys in 125 countries, 63%, whereas the converse was true in 35 countries, 18%, and 42 countries, 21% respectively. In almost all countries for both adults and school-aged children and adolescents, the increases in double burden were driven by increases in obesity and decreases in double burden by declining underweight or thinness. Interpretation: the combined burden of underweight and obesity has increased in most countries, driven by an increase in obesity, while underweight and thinness remain prevalent in South Asia and parts of Africa. A healthy nutrition transition that enhances access to nutritious foods is needed to address the remaining burden of underweight, while curbing and reversing the increase in obesity. Next, we will be discussing articles from Journal of Clinical Oncology, doxorubicin exposure and breast cancer risk in survivors of adolescent and adult Hodgkin lymphoma. Purpose: female Hodgkin lymphoma, HL, survivors treated with chest radiotherapy, RT, at a young age, have a strongly increased risk of breast cancer, BC. Studies in childhood cancer survivors have shown that doxorubicin exposure may also increase BC risk. Although doxorubicin is the cornerstone of HL chemotherapy, the association between doxorubicin and BC risk has not been examined in HL survivors treated at adult ages. Methods: we assessed BC risk in a cohort of 1,964 female 5-year HL survivors, treated at age 15 to 50 years in 20 Dutch hospitals between 1975 and 2008. We calculated standardized incidence ratios, absolute excess risks, and cumulative incidences. Doxorubicin exposure was analyzed using multivariable Cox regression analyses. Results: after a median follow-up of 21.6 years, IQR 15.8 to 27.1 years, 252 women had developed invasive BC or ductile carcinoma in situ. The 30-year cumulative incidence was 20.8%, 95% CI, 18.2 to 23.4. Survivors treated with a cumulative doxorubicin dose of greater than 200 mg/m2 had a 1.5-fold increased BC risk, 95% CI, 1.08 to 2.1, compared with survivors not treated with doxorubicin. BC risk increased 1.18-fold, 95% CI, 1.05 to 1.32, per additional 100 mg/m2 doxorubicin, p-trend equals 0.004. The risk increase associated with doxorubicin, yes v no, was not modified by age at first treatment. Hazard ratio, HR age less than 21 years, 1.5, 95% CI, 0.9 to 2.6, Reg greater than or equal to 21 years, 1.3, 95% CI, 0.9 to 1.9, or chest RT, without mantle/axillary field RT, 1.9, 95% CI, 1.06 to 3.3, Ruth mantle/axillary field RT, 1.2, 95% CI, 0.8 to 1.8. Conclusion: this study shows that treatment with doxorubicin is associated with increased BC risk in both adolescent and adult HL survivors. Our results have implications for BC surveillance guidelines for HL survivors and treatment strategies for patients with newly diagnosed HL. Next, we will be discussing articles from Clinical Gastroenterology. Efficacy and safety of vonoprazan amoxicillin dual regimen with varying dose and duration for Helicobacter pylori eradication, a multi-center, prospective, randomized study. Background and aims. Previous studies confirm vonoprazan amoxicillin effectiveness for Helicobacter pylori. This study aims to investigate vonoprazan with varying amoxicillin dose and duration. Methods. This multi-center, prospective, randomized, controlled, non-inferiority trial enrolled patients with treatment-naive H. pylori infection from 5 clinical centers. Eligible participants were randomly assigned to HVA10, vonoprazan 20 mg twice a day, BID, plus amoxicillin 750 mg 4 times a day. 10 days, LVA10, vonoprazan 20 mg BID, plus amoxicillin 1000 mg BID, 10 days, and HVA14, vonoprazan 20 mg BID, plus amoxicillin 750 mg 4 times a day, 14 days, in a 1:1:1 ratio. The eradication rate was assessed using the 13C urea breath test at least 28 days after treatment. Results. Of the 623 eligible patients, 516 patients were randomized. In both the intention to treat and per protocol analyses, eradication rates were comparable between HVA10 and HVA14 groups, 86.6% versus 89.5% and 90.9% versus 94.5%. P equals 0.021 and 0.013 for non-inferiority, respectively. However, eradication rates were significantly lower in the LVA10 group than the HVA14 group, 79.7% versus 89.5% and 82.0% versus 94.5%, P equals 0.488 and 0.759, respectively. Rates of study withdrawal, loss to follow-up, and adverse events were similar across study groups. Conclusions: HVA10 and HVA14 regimens provide satisfactory efficacy for H. pylori infection, and the LVA10 regimen was inferior. Chronic viral hepatitis B and C outweigh MOSLD and the associated risk of cirrhosis and HCC. Background and aims: the impact of metabolic dysfunction-associated steatotic liver disease, MOSLD, on the development of cirrhosis and hepatocellular carcinoma, HCC, by chronic hepatitis B, CHB, or C infection and antiviral treatment statuses is not well known. Methods: a total of 336,866 adults, aged greater than or equal to 30 years, were prospectively enrolled in a health screening program between 1997 to 2013. MOSLD was identified by abdominal ultrasonography and cardiometabolic profiles. Data linkage was performed using 3 nationwide databases: National Health Insurance, Cancer Registry, and Death Certification System, to obtain information on antiviral treatment, vital status, and newly diagnosed cirrhosis and HCC. Follow-up was conducted until December 31, 2019. Results: in the total population, 122,669, 36.4%, had MOSLD. Over a mean follow-up of 15 years, 5,562 new cases of cirrhosis and 2,273 new cases of HCC were diagnosed. Although MOSLD significantly increased the cumulative risks of cirrhosis or HCC, P less than 0.0001, the associated risk was more pronounced when comparing CHB or C infection with the presence of MOSLD. Stratifying the participants based on their MOSLD and CHB or C statuses, hazard ratios, HRAJ, with 95% confidence intervals for HCC, were 8.81, 7.83 to 9.92. For non-steatotic liver disease, SLD, with CHB or C, 1.52, 1.32 to 1.74. For MOSLD without CHB or C, and 8.86, 7.76 to 10.12. For MOSLD with CHB or C, compared with non-SLD without CHB or C, all P less than 0.0001. Among CHB or C patients who received antivirals during follow-up, MOSLD was associated with increased risks of cirrhosis and HCC, with HRAJ of 1.23, 1.01 to 1.49, and 1.32, 1.05 to 1.65, respectively. Conclusions: these findings underscore the need to prioritize treatment of chronic viral hepatitis before addressing MOSLD. Next, we will be discussing articles from Journal of Clinical Rheumatology. Axial spondyloarthritis. Does magnetic resonance imaging classification improve report interpretation? Objective: the interpretation of magnetic resonance imaging (MRI) reports is crucial for the diagnosis of axial spondyloarthritis, but the subjective nature of narrative reports can lead to varying interpretations. This study presents a validation of a novel MRI reporting system for the sacroiliac joint in clinical practice. Methods: a historical review was conducted on 130 consecutive patients referred by 2 rheumatologists for initial MRI assessment of possible axial spondyloarthritis. The MRI reports were interpreted by the rheumatologists and the radiologist, who originally read the images and then categorized according to the novel system. 2 musculoskeletal radiologists then reinterpreted the original MRI scans using the new system, and the resulting reports were interpreted and categorized by the same rheumatologists. The quality of the new framework was assessed by comparing the interpretations of both reports. Results: 92 patients met the study criteria. The rheumatologists disagreed on the categorization of the original MRI reports in 12% of cases. The rheumatologists and original radiologists disagreed on the categorization of the initial report in 23.4% of cases. In contrast, there was 100% agreement between the rheumatologists and radiologists on the categorization of the new MRI report. Conclusion: the new MRI categorization system significantly improved the agreement between the clinician and radiologist in report interpretation. The system provided a standard vocabulary for reporting, reduced variability in report interpretation, and may therefore improve clinical decision-making. Next, we will be discussing articles from Arthritis and Rheumatology, screening of environmental chemicals to characterize exposures in participants with systemic lupus erythematosus. Objective: there is a need to characterize exposures associated with the pathogenesis of systemic lupus erythematosus, SLE. In this pilot study, we explore a hypothesis-free approach that can measure thousands of exogenous chemicals in blood, exposum, in patients with SLE, and unaffected controls. Methods: this cross-sectional study analyzed a cohort of patients with prevalent SLE, N equals 285, and controls, N equals 106. Plasma was analyzed by liquid chromatography, quadruple time of flight mass spectrometry, LC, KTOF/MS. Mass spectrometry features present in at least 25% of all samples were selected for association analysis, N equals 2,737. Features were matched to potential chemicals using available databases. Association analysis of abundances of features with SLE status was performed, adjusting for age and sex. We also explored features associated with SLE phenotypes, socio-demographic factors, and current medication use. Results: we found 30 features significantly associated with SLE status, Bonferroni p less than 0.05. Of these, 7 matched chemical names based on databases. These 7 features included phthalate metabolites, a formetinate metabolite, and eugenol. The abundance of acid pesticides differed between patients with SLE and controls, Bonferroni p less than 0.05. 2 unmatched features were associated with a history of lupus nephritis, and 1 with anti-double-stranded DNA antibody production, Bonferroni p less than 0.05. 17 features varied by self-reported race and ethnicity, including a polyfluoroalkyl substance, analysis of variance, p less than 1.69 times 10⁻⁵. 11 features correlated with antimalarials, 6 with mycophenolate mofetil, and 29 with prednisone use. Conclusion: this proof-of-concept study demonstrates that LC-KTOF/MS is a powerful tool that agnostically detects circulating exogenous compounds. These analyses can generate hypotheses of disease-related exposures for future prospective, longitudinal studies. Next, we will be discussing articles from Circulation. Clinical impact of routine assessment of patient-reported health status in heart failure clinic, the PRO-HF trial. Background: the impact of routine clinic use of patient-reported outcome, PRO, measures on clinical outcomes in patients with heart failure, HF, has not been well characterized. We tested if clinic-based use of a disease-specific PRO improves patient-reported quality of life at 1 year. Methods: the PRO-HF trial, patient-reported outcome measurement in heart failure clinic, was an open-label, parallel, patient-level, randomized clinical trial of routine PRO assessment, or usual care at an academic HF clinic, between August 30, 2021, and June 30, 2022, with 1 year of follow-up. In the PRO assessment arm, participants completed the Kansas City Cardiomyopathy Questionnaire 12, KCCQ-12, at each HF clinic visit, and results were shared with their treating clinician. The usual care arm completed the KCCQ-12 at randomization and 1 year later, which was not shared with the treating clinician. The primary outcome was the KCCQ-12 Overall Summary Score, OSS, between 12 and 15 months after randomization. Secondary outcomes included domains of the KCCQ-12, hospitalization and emergency department visit rates, HF medication therapy, clinic visit frequency, and testing rates. Results. Across 17 clinicians, 1,248 participants were enrolled and randomized to PRO assessment, N equals 624, or usual care, N equals 624. The median age was 63.9 years, interquartile range, IQR, 51.8 to 72.8, 38.9% were women, and the median baseline KCCQ-12 OSS was 82.3, IQR, final KCCQ-12, available in 87.9% of the PRO arm and 85.1% in usual care. P equals 0.16, median OSS were 87.5, IQR, 68.8 to 96.9, in the PRO arm and 87.6, IQR, 69.7 to 96.9, in the usual care arm with a baseline adjusted mean difference of 0.2, 95% CI, minus 1.7 to 2.0, P equals 0.85. The results were consistent across pre-specified subgroups. A post-hoc analysis demonstrated a significant interaction with greater benefit among participants with a baseline KCCQ-12 OSS of 60 to 80, but not in less or more symptomatic participants. No significant differences were found in one-year mortality, hospitalizations, emergency department visits, medication therapy, clinic follow-up, or testing rates between arms. Conclusions. Routine PRO assessment and HF clinic visits did not impact patient-reported quality of life or other clinical outcomes. Alternate strategies and settings for embedding PROs into routine clinical care should be tested. Next, we will be discussing articles. American College of Cardiology. Degenerative MR due to flail leaflet according to sex. Study questions. What are the sex-specific baseline clinical and echocardiographic characteristics at referral for degenerative mitral regurgitation, DMR, due to flail leaflets and subsequent management and outcomes? Methods. The investigators compared females with males regarding presentation at referral, management and outcome, survival/heart failure, HF, under medical treatment, postoperatively, and encompassing all follow-up in the Mitral Regurgitation International Database, MIDA, International Registry. Primary endpoints were mortality and HF under conservative treatment, after surgical correction of DMR, and throughout follow-up, including conservative and surgical management. The secondary endpoint was performance of mitral surgery during follow-up. Comparison between males and females used Key2 test, or Fisher exact test, and student's t-test, or Mann-Whitney test. Event incidence rates were estimated using Kaplan-Meier method. Univariable and multivariable Cox models allowed estimation of crude and adjusted hazard ratios, HRs, with 95% confidence interval, CI. Results. At referral, females, N equals 650, versus males, N equals 1,660, were older, with more severe symptoms, and had a higher MIDA score. Smaller cavity diameters belied higher cardiac dimension indexed to body surface area. Under conservative management, excess mortality versus expected was observed in males, standardized mortality ratio, SMR, 1.45, 1.27 to 1.65, p less than 0.001, but was higher in females, SMR 2.00, 1.67 to 2.38, p less than 0.001. Female sex was independently associated with mortality. Adjusted HR 1.29, 1.04 to 1.61, p equals 0.02, cardiovascular mortality, adjusted HR 1.58, 1.14 to 2.18, p equals 0.007, and HF, adjusted HR 1.36, 1.02 to 1.81, p equals 0.04. Under medical management, females versus males were less offered surgical correction, 72% versus 80%, p less than 0.001. However, surgical outcome, adjusted for more severe presentation in females, was similar, p greater than or equal to 0.09. Ultimately, overall outcome throughout follow-up was worse in females who displayed persistent excess mortality versus expected. SMR, 1.31, 1.16 to 1.47, p less than 0.001, whereas males enjoyed normal life expectancy restoration, SMR 0.92, 0.85 to 0.99, p equals 0.036. Conclusions. The authors report that females with severe DMR were referred to tertiary centers at a more advanced stage, incurred higher mortality and morbidity under conservative management, and were offered surgery less and later after referral. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Orthostatic hypotension promotes the progression from mild cognitive impairment to dementia in type 2 diabetes mellitus. Context. In type 2 diabetes mellitus, T2DM, orthostatic hypotension, O, is associated with cognition, but the mechanisms governing the link between O and cognition are still unclear. Objective. We sought to analyze Alzheimer's disease, AD biomarkers, and the part of complement proteins in modulating the association of O with cognitive impairment, and examine whether O could accelerate the clinical progression of mild cognitive impairment, MCI, to dementia in T2DM. Methods. We recruited patients with T2DM with MCI and collected general healthy information and blood samples. Complement proteins of astrocyte-derived exosomes were isolated and AD biomarkers of neuronal cell-derived exosomes isolated were quantified by enzyme-linked immunosorbent assay. Cognitive assessments were performed at patient enrollment and follow-up. Results. Mediation analysis showed that the influence of O on cognition in T2DM was partly mediated by baseline AD biomarker. Next, we will be discussing articles from Neurology. Effect of endovascular thrombectomy for acute ischemic stroke on cognitive outcomes, a secondary analysis of the ESCAPE trial. Background and objectives. The effect of endovascular therapy, EVT, for large vessel occlusion stroke on cognitive outcomes is not well understood. We evaluated the effect of EVT on cognitive function in the endovascular treatment for small core and anterior circulation proximal occlusion, with emphasis on minimizing CT to recanalization times. ESCAPE trial. Methods. Patient data from the ESCAPE randomized trial were analyzed. Cognitive assessments completed at 90 days after stroke were the Montreal Cognitive Assessment, MoCA, the Sunnybrook Neglect Assessment Procedure, SNAP, the Boston Naming Test, BNT, Trail-Making Test A, Trails A, and Trail-Making Test B, Trails B. We used logistic regression to evaluate the association between EVT and favorable cognitive outcome on the 5 separate tests, adjusting for demographic and clinical factors. We used generalized estimating equations and ordinal regression to determine the odds of favorable outcome with EVT on global cognition incorporating the 5 tests. We added final infarct volume, FIV, to the models to assess the relationship of 5 with cognitive outcome. Results. The ESCAPE trial included 315 patients, 165 randomized to EVT, and 150 randomized to control. There was higher odds of favorable outcome with EVT for MoCA, adjusted odds ratio, AOR, 2.32, 95% CI, 1.30 to 4.16, SNAP, AOR 3.85, 95%, CI 2.00 to 7.45, BNT, AOR 2.33, 95% CI, 1.30 to 4.17, Trails A, AOR 3.50, 95% CI, 1.93 to 6.36, and Trails B, AOR 2.56, 95% CI 1.46 to 4.48. There was higher odds of favorable outcome with EVT on global binary, AOR 2.57, 95% CI 1.67 to 3.94, and ordinal analyses, AOR 2.83, 95% CI 1.68 to 4.76 of cognitive function. After adding 5 to the models, both 5 and EVT were significantly associated with cognitive outcome. There was a significant correlation between global cognitive performance and misses at day 90, R equals -0.78, P less than 0.001, with the largest reductions in favorable cognitive outcome from misses score 4 to 5, and from misses 2 to 3. Discussion. In this secondary analysis of the ESCAPE trial, EVT was associated with favorable outcome on 5 separate cognitive tests and in global analyses of cognitive benefit. These results provide novel evidence for the effect of EVT on cognition and support the global benefit of treatment with EVT. Next, we will be discussing articles from CHEST. Safety and efficacy of clofazimine as an alternative for rifampicin in Mycobacterium avium complex pulmonary disease treatment. Background. Results of retrospective studies have suggested clofazimine as an alternative for rifampicin in the treatment of Mycobacterium avium complex pulmonary disease, MAC-PD. Research question. Is a treatment regimen consisting of clofazimine ethambutol macrolide non-inferior to the standard treatment regimen, rifampicin ethambutol macrolide, in the treatment of MAC-PD? Study design and methods. In this single-center, non-anonymized clinical trial, adult patients with MAC-PD, randomly assigned in a 1-to-1 ratio, to receive rifampicin or clofazimine as adjuncts to an ethambutol macrolide regimen. The primary outcome was sputum culture conversion following 6 months of treatment. Results. 40 patients were assigned to receive either rifampicin, N equals 19, or clofazimine, N equals 21, in addition to ethambutol and a macrolide. Following 6 months of treatment, both arms showed similar percentages of sputum culture conversion based on an intention to treat analysis, 58%, 11 of 19, for rifampicin and 62%, 13 of 21, for clofazimine. Study discontinuation, mainly due to adverse events, was equal in both arms, 26% versus 33%. Based on an on-treatment analysis, sputum culture conversion following 6 months of treatment was 79% in both groups. In the clofazimine arm, diarrhea was more prevalent, 76% versus 37%, P equals 0.012, while arthralgia was more frequent in the rifampicin arm, 37% versus 5%, P equals 0.011. No difference in the frequency of corrected QT interval prolongation was seen between groups. Interpretation. A clofazimine ethambutol macrolide regimen showed similar results to the standard rifampicin ethambutol macrolide regimen and should be considered in the treatment of MAC-PD. The frequency of adverse events was similar in both arms, but their nature was different. Individual patient characteristics and possible drug-drug interactions should be taken into consideration when choosing an antibiotic regimen for MAC-PD. Comparison of pirfenidone and nintedanib. Background. Antifibrotics are effective in slowing FVC decline in idiopathic pulmonary fibrosis, IPF. However, whether antifibrotic type is differentially associated with FVC decline remains inconclusive. Research question. Are there significant differences in 12-month FVC decline between pirfenidone and nintedanib? Study design and methods. A post-hoc analysis was performed using the clinical efficacy of antimicrobial therapy strategy using pragmatic design in IPF. Cleanup IPF, trial, No. NCT 027592120. Participants who reported using pirfenidone or nintedanib on enrollment into the trial were in the primary analysis. Spirometry was scheduled at baseline and the 12 and 24-month study visits. Linear mixed effects models with random intercept and slope were used to examine changes in FVC over time. Models were adjusted for age, sex, smoking history, coronary artery disease history, baseline FVC, and 12-month spline term. Survival and non-elective respiratory hospitalization by antifibrotic type were determined using Cox regression models with adjustment for age, sex, smoking history, coronary artery disease history, and baseline FVC and diffusing capacity for carbon monoxide. Results. Out of the 513 participants with IPF randomized in the CleanUP IPF trial, 407 reported using pirfenidone, N equals 264, 65%, or nintedanib, N equals 143, 35%. The pirfenidone group had more participants with a history of coronary artery disease than the nintedanib group, 34.1% versus 20.3% respectively. Patients treated with nintedanib had a higher 12-month visit FVC than patients treated with pirfenidone. Mean difference, 106 milliliters, 95% CI, 34 to 178. This difference was attenuated at the 24-month study visit. There were no significant differences in overall survival and non-elective respiratory hospitalization between the pirfenidone and nintedanib treated groups. Interpretation. Patients with GONS, IPF who used nintedanib had a slower 12-month FVC decline than pirfenidone in a post-hoc analysis of a clinical trial. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology, Preventive Pharmacological Therapy and Risk of Recurrent Urinary Stone Disease. Background. Urinary stone disease is a prevalent condition associated with a high recurrence risk. Preventive pharmacological therapy has been proposed to reduce recurrent stone episodes. However, limited evidence exists regarding its effectiveness, contributing to its underutilization by physicians. This study aimed to evaluate the association between preventive pharmacological therapy, thiazide diuretics, alkali therapy, and uric acid lowering medications, and clinically significant urinary stone disease recurrence. Methods. Using data from the Veterans Health Administration, adults with an index episode of urinary stone disease from 2012 through 2019, and at least one urinary abnormality, hypercalciuria, hypocitraturia, or hyperuricosuria, on 24-hour urine collection were included. The primary outcome was a composite variable representing recurrent stone events that resulted in emergency department visits, hospitalizations, or surgery for urinary stone disease. Cox proportional hazards regression was performed to estimate the association between preventive pharmacological therapy use and recurrent urinary stone disease, while adjusting for relevant baseline patient characteristics. Results. Among the cohort of patients with urinary abnormalities, N equals 5637, treatment with preventive pharmacological therapy was associated with a significant 19% lower risk of recurrent urinary stone disease during the 12-36-month period after the initial urine collection. Hazard ratio 0.81, 95% confidence interval 0.65 to 1.00, p equals 0.0496. However, the effectiveness of preventive pharmacological therapy diminished over longer follow-up periods, 12 to 48 and 12 to 60 months after the urine collection, and did not reach statistical significance. When examining specific urinary abnormalities, only alkali therapy for hypocitraturia was associated with a significant 26% lower recurrence risk within the 12-36-month timeframe. Hazard ratio 0.74, 95% confidence interval 0.56 to 0.97. P equals 0.03. Conclusions. When considering all urinary abnormalities together, this study demonstrates that the use of preventive pharmacological WAJ therapy is associated with a lower risk of clinically significant recurrent episodes of urinary stone disease in the 12 to 36-month timeframe after urine collection, although only the association with the use of alkali therapy for hypocitraturia was significant when individual abnormalities were examined. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology, Preventive Pharmacological Therapy and Risk of Recurrent Urinary Stone Disease. Background. Urinary stone disease is a prevalent condition associated with a high recurrence risk. Preventive pharmacological therapy has been proposed to reduce recurrent stone episodes. However, limited evidence exists regarding its effectiveness, contributing to its underutilization by physicians. This study aimed to evaluate the association between preventive pharmacological therapy, thiazide diuretics, alkali therapy, and uric acid-lowering medications, and clinically significant urinary stone disease recurrence methods. Using data from the Veterans Health Administration, adults with an index episode of urinary stone disease from 2012 through 2019, and at least one urinary abnormality, hypercalciuria, hypocitraturia, or hyperuricosuria, on 24-hour urine collection were included. The primary outcome was a composite variable representing recurrent stone events that resulted in emergency department visits, hospitalizations, or surgery for urinary stone disease. Cox proportional hazards regression was performed to estimate the association between preventive pharmacological therapy use and recurrent urinary stone disease, while adjusting for relevant baseline patient characteristics. Results. Among the cohort of patients with urinary abnormalities, N equals 5637, treatment with preventive pharmacological therapy was associated with a significant 19% lower risk of recurrent urinary stone disease during the 12-36-month period after the initial urine collection, hazard ratio, 0.81, 95% confidence interval, 0.65 to 1.00, p equals 0.0496. However, the effectiveness of preventive pharmacological therapy diminished over longer follow-up periods, 12 to 48 and 12 to 60 months after the urine collection, and did not reach statistical significance. When examining specific urinary abnormalities, only alkali therapy for hypocitraturia was associated with a significant 26% lower recurrence risk within the 12-36-month timeframe. Hazard ratio, 0.74, 95% confidence interval, 0.56 to 0.97. P equals 0.03. Conclusions. When considering all urinary abnormalities together, this study demonstrates that the use of preventive pharmacological WAJ therapy is associated with a lower risk of clinically significant recurrent episodes of urinary stone disease in the 12 to 36-month timeframe after urine collection, although only the association with the use of alkali therapy for hypocitraturia was significant when individual abnormalities were examined. Next, we will be discussing articles is from Clinical Journal of American Society of Nephrology, Preventive Pharmacological Therapy and Risk of Recurrent Urinary Stone Disease. Background. Urinary stone disease is a prevalent condition associated with a high recurrence risk. Preventive pharmacological therapy has been proposed to reduce recurrent stone episodes. However, limited evidence exists regarding its effectiveness, contributing to its underutilization by physicians. This study aimed to evaluate the association between preventive pharmacological therapy, thiazide diuretics, alkali therapy, and uric acid-lowering medications, and clinically significant urinary stone disease recurrence methods. Using data from the Veterans Health Administration, adults with an index episode of urinary stone disease from 2012 through 2019, and at least one urinary abnormality, hypercalciuria, hypocitraturia, or hyperuricosuria, on 24-hour urine collection were included. The primary outcome was a composite variable representing recurrent stone events that resulted in emergency department visits, hospitalizations, or surgery for urinary stone disease. Cox proportional hazards regression was performed to estimate the association between preventive pharmacological therapy use and recurrent urinary stone disease, while adjusting for relevant baseline patient characteristics. Results. Among the cohort of patients with urinary abnormalities, N equals 5637, treatment with preventive pharmacological therapy was associated with a significant 19% lower risk of recurrent urinary stone disease during the 12-36-month period after the initial urine collection, hazard ratio, 0.81, 95% confidence interval, 0.65 to 1.00. P equals 0.0496. However, the effectiveness of preventive pharmacological therapy diminished over longer follow-up periods, 12 to 48 and 12 to 60 months after the urine collection, and did not reach statistical significance. When examining specific urinary abnormalities, only alkali therapy for hypocitraturia was associated with a significant 26% lower recurrence risk within the 12-36-month timeframe. Hazard ratio, 0.74. 95% confidence interval, 0.56 to 0.97. P equals 0.03. Conclusions. When considering all urinary abnormalities together, this study demonstrates that the use of preventive pharmacological WAJ therapy is associated with a lower risk of clinically significant recurrent episodes of urinary stone disease in the 12 to 36-month timeframe after urine collection, although only the association with the use of alkali therapy for hypocitraturia was significant when individual abnormalities were examined. Next way we'll be discussing articles is from Kidney International Reports. Effectiveness of molnupiravir and nirmatrelvir ritonavir in CKD patients with COVID-19. Introduction. Even with effective vaccines, patients with CKD have a higher risk of hospitalization and death subsequent to COVID-19 infection than those without CKD. Molnupiravir and nirmatrelvir ritonavir have been approved for emergency use, but their effectiveness for the CKD population is still unknown. This study was conducted to determine the effectiveness of these drugs in reducing mortality and severe COVID-19 in the CKD population. Methods. This was a target trial emulation study using electronic health databases in Hong Kong. Patients with CKD aged 18 years or older who were hospitalized with COVID-19 were included. The per-protocol average treatment effect among COVID-19 oral antiviral initiators, including all-cause mortality, intensive care unit, ICU, admission, and ventilatory support, within 28 days, were compared to non-initiators. Results. Antivirals have been found to lower the risk of all-cause mortality, with molnupiravir at a hazard ratio, HR, of 0.85, 95% confidence interval, CI, 0.77 to 0.95, and nirmatrelvir ritonavir at an HR of 0.78, 95% CI, 0.60 to 1.00. However, they do not significantly reduce the risk of ICU admission. Molnupiravir, HR, 0.88, 95% CI, 0.59 to 1.30. Nirmatrelvir, ritonavir, HR, 0.86, 95% CI, 0.56 to 1.32, or ventilatory support. Molnupiravir, HR, 1.00, 95% CI, 0.76 to 1.33. Nirmatrelvir ritonavir, HR, 1.01, 95% CI, 0.74 to 1.37. There was a greater risk reduction in males, and those with higher Charlson Comorbidity Index, CCI. The nirmatrelvir ritonavir trial also showed reduced risk for those who had antiviral treatment and received 3 or more vaccine doses. Conclusion. Both molnupiravir and nirmatrelvir ritonavir reduced mortality rates for hospitalized COVID-19 patients with CKD.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.